Good afternoon, ladies and gentlemen, and welcome. Today it's the 100th day of lockdown. You haven't noticed that, you have now. And what better way to spend it, at least part of the day, with the company of RSM Live and today's all-star panel. Now, this webinar is very international, and we've been watched all around the world, so much so that I found out a couple of weeks ago from our friends in Sydney that the picture that I had behind me was, as they said, wonky. I'm very pleased to say that it's now back from the framers as completely stable and level, which is far more than can be said about the global pandemic at the moment. So who are we here today? Well, it's our monthly catch-up with all the hundreds and hundreds of questions that you've been asking over the last 8 webinars that we did during the month of June. And therefore, whatever else the panel do, they're going to have to be swift in their answers because we've got a lot to get through. Who have we got? Well, coming back is Professor Peter Openshaw, making his 3rd or 4th appearance, I think. Professor of Experimental Medicine, a respiratory physician at Imperial, also on NervTAC, the government's main advisory committee for the new respiratory viruses. Joining us for the first time is Professor Nick Patel, chair of the academic board at the RSM and cardiologist, deputy chief of medicine down at Eastbourne. And also newcomer today is Professor Sian Griffiths, something of a legend in public health circles. I remember when I was young and a student, you were already the director of public health, I think, at Oxford, regional director, became a major player in global public health, chaired the Faculty of Public Health in the UK, and also spent a long time in Hong Kong, where she led the Hong Kong government inquiry into SARS. Indeed, no doubt your phone will be ringing soon to ask you to take over such an inquiry here. But what we're going to do, it will be. So I thought we'd start off with what we've done last time, and this is a quick round of desert island papers. This is when I ask you to bring just one paper that's attracted your attention in the last few weeks, something to do, or a paper, or a record, or a report, or whatever, something just to highlight something that's caught your eye in the last few weeks. So Peter, let's start off with you. What have you got today?
Well, I think I'm going to name something which is maybe a bit of a surprise, since we don't think of COVID as being a pediatric disease. But I'm particularly intrigued by a series of papers that are coming out about this multi-system inflammatory disorder in children. So Liz Whitaker and Mike Levine came out with a paper which was published in JAMA just recently, where they described a series of 58 children who hadn't got COVID, but who presented with multi-system inflammatory disorder. And I think it's really interesting because it's a disease which clearly is triggered by COVID, but is not itself a presentation of the acute disease. And I think it makes you think about all those other inflammatory disorders and long-term immunological diseases, which we think might be triggered by a virus, but we actually don't know that they are. So to me, it's intriguing, and it's very thought-provoking, and also important in that there are now about 1,000 children around the world who have been described with this condition.
Great, thank you very much. I have a bleeping fridge in the background, whatever that means, I really don't know. So Nick, what have you got to bring to the table now?
Well, I could have been traditional and talked around heart attacks and the reduction of patients coming to the A&E department with less heart attacks, and a paper recently around the increase in cardiac arrest in the community of around 50%. But I'm not going to do that. What really caught my eye is the press and papers around inequality. And there's a good article from the BMJ, an editorial, talking about racism in the new pandemic, really outlining the inequalities of healthcare and how racism is a really social problem, not necessarily a biological one. And it brings out all those emotions that we have around fear, anxiety, anguish, people feeling powerless, as we have done within the COVID itself. But it also raises the spectre of racism on our society and the damage it does, whether it's sort of unwitting prejudice or ignorance, thoughtlessness, stereotyping. But at the end of the day, it leads to a disadvantage for the minority groups, and it affects us all. And I think that really has stirred the emotions within myself. And what we should do going forward.
I mean, just push on a little with that theme then, if you want. How are you responding in your? I mean, you're whenever time I see you, you're always in in clinical gear. So you're obviously very active on the clinical front, even as we speak. How are you responding to this at Eastbourne, where you work?
Well, I think there's 2 or 3 elements. It's around patient education and communication, but also, more importantly, around our health staff and recognising the issues with the BAME group, the increased vulnerability, and allowing us to get the assessment right and coming with a series of guidelines around what individual workers can do. But it also highlights the importance of having networks and being inclusive. Our sort of goal command in initial stages perhaps didn't have the diversity in the hospital that it probably should have, to address all the groups, all the minority groups.
Okay, thank you very much. And Sian, what's your desert island dish for today?
Thanks, Simon. Well, I've chosen a paper that was written by colleagues in Hong Kong called "What Can Countries Learn from Hong Kong's Response to the COVID-19 Pandemic?" And I've done that for several reasons. One is because I think we need to learn from the past, such as the SARS epidemic in Hong Kong. There were a lot of lessons, and Hong Kong then responded extremely quickly. They didn't even wait for any cases before they brought in border controls in Hong Kong, between Hong Kong and China. So there were no cases. They've also continued to control the disease really well. There've only been 8 deaths altogether. They've really ramped up the test and tracing, the isolation, the quarantine. They've controlled the flow of people coming into the country. And so they've done really well, but it's as much that the population have complied. The authors postulate that actually, having gone through the experience of SARS, the population were very quick to adopt mask wearing, very quick to agree to social distancing, to setting up teaching of school children didn't go to school, but the lessons were relayed home. And of course, Hong Kong's lucky because it's got very good IT and ability to do that. So I think it's a very good lesson in that, hopefully when we look forward, that we will have learned from COVID, that we will have learned from the lessons, and that next time round it won't be have such a devastating impact.
I mean that's such a huge subject. I was going to ask you about it later, but I might as well do it now. And I was going to quote back from you a couple of lines from your paper 2005, just to see if you recognise that wasn't the current it was before. But the one thing I've always intrigued me is that the experience of SARS that we didn't have must have kind of sensitized the kind of officialdom, as it were, the public health structure, etc., and the population in a way that, our last experience with swine flu, it was a bit of a kind of damp squib in many respects, and people wondered about crying wolf. But do you think that actually SARS was a godsend for you because it meant that you gained that extra time and also in preparation, or it was just good luck?
No, I think if you look to Southeast Asia and you look to the countries that did experience SARS, you'll see that that they were all sensitized, as you say. It was a sensitization. When we did the inquiry, we drew out lessons to learn, and you could apply them all the way through this pandemic. Not everyone has learned the lessons, but in Hong Kong they have learned the lessons. And we called SARS the wake-up call. But the other thing was that it was really the fall in the GDP, which made everybody sit up. So by the summer of SARS, the GDP had fallen, and people were going, this isn't just about a health outbreak, a disease outbreak, this is actually affecting the whole of our futures. And it led to quite a lot of change in policy in Hong Kong because of that. So, and as it did in Taiwan and Korea, who've also done very well during this epidemic, they know that non-pharmaceutical interventions, public health interventions were absolutely key, especially if you haven't got a vaccine.
Okay. Well, I'm sure both of those will come back to. I just need to ask the panelists if you've been irritated by my fridge alarm that I'm unable to turn off. If you are, I'm going to move rooms, but if you're not bothered by it,
it's all right, Simon.
It's okay, is it? I feel my supply of ice cream is going to start melting over and sweep towards us in a kind of tidal wave of cream any moment now. I do apologise for that. Okay, now, so let's start picking up some of the themes that we developed over the last month, and we did a session with the leaders of the think tanks a couple of weeks ago. And that was about preparing for the future. And there were a lot of questions that we didn't get around to asking. I think I can I can go over a couple of those. And I think one of the ones we never got round to was talking about the issues between secondary care. At the moment, where people are being kept out of secondary care. But how do we think those kind of patients will access specialist care in the future? Should we go back to where we were? Should we find different ways? How are we preparing now to restore secondary care services to all those who've been missing? So Nick, do you want to kick off on that and how it is for cardiology? Or indeed, General Med, you're the Director of General Medicine anyway, so you can make it as broad as you want.
Yeah. Well, I mean, I think there's no doubt that healthcare in the past wasn't ideal. I think what we were delivering before was heavy, wasn't it? It was a lot of outpatients, a lot of investigations, and it was the nature of medicine that we had at the time. And I think that things need to change generally. I think we need to learn to be slightly risk averse, and that will allow good old-fashioned clinical acumen to come into play. With the community, what we've learned is that things have changed, and we're able to consult using digital, using technology that we talked about and never really did. And so specialist opinion can be given in the community very easily, and we're doing it day by day. And I have a number of colleagues who were reticent about using technology and now wouldn't go back. So I think there are lessons that we've learned that mean that technology has helped us, ways of working have changed to help us deal with the community. And I think pre-COVID, we were getting there, really. We were getting healthcare and social care growing together, coming together to allow us to develop community care in a better way. That's with education, self-help. That's with community care, with multi-agency support. But in actual delivery of medicine in the community, I think the setup of hubs, regional diagnostic centres, access to those will allow us to do a lot of the investigations, a lot of the consultations without having to access the emergency end of secondary care.
I mean, I remember all that happening at one of the acute hospitals I worked in, or been talked about some years ago, about how the physicians were going to move to be closer to the patient, et cetera, which I thought would herald a big shift into community services. What it actually meant is more of them would actually go down into A&E when they were called. It isn't what I would call community care. Are you sure this time it is going to happen? There will be a reshaping of resource and more of you will be genuinely working in community-based centres?
Yeah, I think the impediment was time and travel, wasn't it? I think the impediment was that we were having to split our time, and half the time was spent travelling to go to our community clinics when that was fashionable. With the technology, that's much easier, and even my colleagues in primary care who have adopted technology have said they won't go back. So I think it's going to be a lot easier for patients to be able to get the contact and the communication they require. I think the frustration and why people go to A&E is they can't talk to anybody. And we now have a plethora of different agencies, whether it's 111, whether it is digital consultations, video consultations, will allow patients to feel they're being listened to and to get advice.
But Sian, you must have also wasted an awful amount of time, energy, etc., at various stages in your career in trying to achieve these major service changes and challenges. From the public health perspective, expecting change or not?
I think that the accessibility of, let me just take, for example, this Zoom call we're on now, the accessibility of people and the way people are patients themselves are getting much more familiar, or people in general are getting much more familiar with the use of IT. And I think there'll be a lot more messaging, there'll be a lot more discussion discussion groups, and you'll be able to do a lot more in terms of getting the clarity of message using telecommunications. And I think it's as much a change from the patient's point of view as it is from the doctor's point of view. It will no longer seem strange to have a telephone call or to do a chat like this with your doctor or with the nurse or or with whoever, and you'll be able to sort a whole lot of things out, including anxiety. If you just a small query when you would normally have gone rushing along to wait for hours to not necessarily get the answer you want, you'll be able to do it like this. So I think this is this way of communicating is here to stay.
Okay, I had to go to our urgent care centre because I fell off my bike last week and took along a major, War and Peace to read. I didn't even manage to open it because everything was so quick. It was ridiculously quick and over. I was disappointed. I was looking forward to having a full read. Okay, so Peter, let's go back to one of the, as you are our old timer on this, let's have a question that keeps coming back, and let's see if you can add more light to this. And I think this is the third time that I've asked you this, but again, at least 10 questions, variations on the theme, all of which are, what do we know about individuals who've recovered from a COVID-19 infection and their possibility of getting reinfected? How we got? Are we further along with that than we have been when we've asked you before?
We still don't know, and it's incredibly frustrating. I mean, I was hoping that that our colleagues in the Far East were going to be able to tell us, because they saw it first, but they've been so effective in some areas in eliminating infection that they haven't yet been able to tell us whether you can get infected twice, and they're actually asking us to tell them when we find out, because we haven't eliminated it. It's still out there in the community in quite large numbers, and I think we're going to discover when we get a resurgence in the autumn, which we're pretty confident we will, whether people who were infected the first time round can get infected again. So at the moment, we still don't know what it means when you have a positive antibody test. I think we're all secretly hoping that it means that we are immune and that we're protected against reinfection, but that's not clear, and we still don't know about the possibility of antibody enhancement. All of this is crucial to the development of vaccines, which seems the only viable exit strategy from this situation that we're in.
A bit. I've managed to mute myself, I think now. No, I'm sorry, I'm back there again. Yeah. I managed to mute myself. When this is all over, if anyone ever says once again to me, Simon, you're muted, I think I will commit murder. But just before that, that leads us on to something again was going to come up later, but we might as well go to now and get everyone's views on this. And this is the issue that seems to have resurfaced in the last few days as antibody testing is getting more up to speed, which is the idea of immune passports. That another way out of the mess we're in, not just vaccines, is that the people who can show immunity, this is the theory, would be then able to participate more in all sorts of different activities that they could do at the moment. So the immune passport idea, who wants to kick off on that one? Sian, do you want to pick off from the public?
As I understand it, I'm not close to the science, and the others would have more detail. But the concept would be that if you are able to show you're immune, then you would be able to go back to the front line of the healthcare system. You'd be able to travel on airlines, etc. So it's a very neat idea, and it's a little bit based in Wuhan. They were having a Q code on their phones, a green Q code, to say you did have you've had the infection, you've got antibodies, but nobody actually knows how long the antibodies are going to last, or how protective they are, or what that really means. And so I think it's an idea, but it's not one that has yet got much traction. Looking, the Public Health England are using antibody testing to look at surveillance in the population, to look at levels of infection. So it's not just people who are coming forward; they're doing that sort of work, and so it's useful epidemiologically. But whether it's useful on an individual basis as a passport, I think is as yet unknown. I'd stand to be corrected.
Okay, I mean clearly we should be doing it as part of research. That's for sure. But that is the question that's been asked. Would this be used for individuals? Nick, do you have any views on that?
Equally, I think the idea is neat, isn't it? I think there's the ability to be able to move freely, and also for our healthcare workers on the front line to know that they are in theory safe would be brilliant. I guess the question is, the volume of testing that's required. who's it available to? Is it going to be available to everybody? And there's a question around that, and a question I can't answer is the reliability of the test. Are we 100% sure it's going to be confer immunity in the future?
I mean, I think that is a critical question. Certainly, one of my colleagues, James Rubin, did a study that showed that people who thought that they'd had it, whether they had or hadn't, behaved quite differently to people who thought they hadn't had it. And given the fact that the tests are still not 100% reliable, and there would be a danger that people actually were still at risk, or indeed conveying risk, would behave in a way that they wouldn't otherwise. So I think there are big risks to it. And then the other big risk, if that's the way to get yourself out of this dilemma, and then the only way you can get back to work or pleasure, leisure, etc., is to get a passport. The possibilities for fraud or for COVID parties among young people, etc., would be quite immense. I think it'd be very, very, very difficult to do actually in practice, I have to say. But it's come up. Several people have asked it, and it has a seductive value, doesn't it? I agree.
Yeah. Does it not promote? Does it not promote that inequality that I detest so much? It'd be those that have the passport and those that don't, and their liberties are very different between the two groups. So I'm with you. I'm worried.
And if you want to see examples of that happening, just look at the historical literature. In a very good article in the New York Times a couple of weeks ago, looking back at yellow fever passports in the south of the USA and how they were used. So yellow fever passports in the southern USA in the pre-Civil War period and after the Civil War is a very salutary and pretty sickening story. So I think we're a long way to go before we get there. Now then, another question's come up again. This came up really in the very first one we had about 12 weeks ago. Oh, happy days that was. And this is the idea that something in the past that you've had, be it the flu jab or pneumonia or whatever, BCG came up in episode 3 and again in episode 10. This idea that, is there anything that we know in terms of your prior vaccination or prior infection that seems to either reduce the chance of getting COVID or at least its severity? Pete, do you want to start off on that one?
Yeah, that's a really interesting, difficult question. There's been,
you don't know the answer, do you?
No, I don't know the answer to it. No, maybe I should stop there.
No, go on then.
I mean, we do know that you can stimulate the innate immune response, and that the innate immune response in your mucosal surface is very important and probably prevents maybe at least half of the infections. In some challenge studies that we've been doing in volunteers with influenza and RSV, we're trying to explain why it is that some people just don't take the virus, even though we directly inoculate it up the nose. And it seems to us that it is that innate state of readiness of the mucosa, and we don't know what it is which is causing that, but we think that it must be a past history of other viruses which have been in there and which have tickled up the innate immune system and made it stand ready to defend itself when the first encounter with a novel virus happens. I think there's an awful lot there in the nasal mucosa which we don't really yet know about in terms of immunology, and to put it all down to just antibody or maybe antibody and T cells, if you want to be a bit more sophisticated, is not enough, because the whole world of innate immunology is going on, and that probably is why things like BCG and other vaccines against irrelevant things can actually modulate your immune response to a pathogen which is trying to gain a foothold.
Okay, and anyone else want to come in on that question? Prior protection in any shape or form? Is there an angle here, Sian, for you?
Not so much prior protection, but the urge for people to have the flu vaccine once the winter comes along, in preparation for winter, to protect themselves from getting flu when they're at risk of also getting COVID. CDC, US CDC are particularly pushing this message at the moment to raise the numbers of people who have the flu vaccine, because if we can diminish the demands on the health system by getting adequate levels of flu vaccination, should we have another surge of COVID, it just will help us to cope better.
Okay. And still on the context of immunity and respiratory illness, lots of questions came up a couple of times ago on asthma. And we might kick off with you on this one, Nick. And I counted 10 at least, all from health professionals with asthma, and all of them touching on either the long-lasting risks of asthma in a COVID world, or another who said, I quote, "I have severe asthma. Will I ever be able to work in a hospital role again?" Nick, what's your view on that? First of all, in terms of the workforce.
I feel like answering like Peter to start with. I think the answer is that the evidence base is not there really at the moment. I think there's a sort of direct link between asthma and having COVID and a thought around respiratory illnesses, but we know that the real risk factors are diabetes, ethnicity, hypertension, coronary disease. It's not asthma. I think where asthma has a role to play is if with having asthma you've had steroids within the last 3 months or have an immunocompromised possibility, that's the situation in which you'd exhibit caution around working on the front line. But I would put it back there that the evidence is not there that asthma stops you working on the front line. It is the adjuvant immune system, with steroid use, etc. That's a real issue.
And Peter, you're not just a respiratory physician. You mentioned in the past that you yourself have asthma.
Yes, yes.
How, speaking as either one or the other, for the professionals, elucidate a bit more for us.
Yeah, so people with severe asthma were put on the shielding list, but that was on the basis of what we knew about influenza. And in the study that we did back in 2009, 2010 on severe hospitalized influenza, about 30% of the patients had asthma. So it was a major risk factor, but actually they did relatively well once they were in hospital. So, on the basis that this was sort of a bit like flu, when the shielding list was drawn up, asthma was on it. But I think the studies which are coming out, including Ben Goldacre's study of 17 million people, shows that actually ordinary regular asthma is not a risk factor. If you're on asthma, and if you have asthma and you're on steroids, then it becomes a risk factor. I think the question about whether if you're on these various depleting drugs that are now being used for asthma, the biologics, whether that makes you susceptible, I don't think we know. If you're on benralizumab or one of the other drugs which are used for immune modulation, I think probably those don't put you at particular risk. And there was a study just came out from Italy where they looked at patients who were on a range of biologics for inflammatory disorders, rheumatological disorders, and that doesn't actually seem to put people at a special risk. And indeed, some of those, like anti-IL-6 and anti-GM-CSF, are being used now to treat the sort of second inflammatory phase of COVID. So I think we need to sort of revise our thinking about risk factors now that we're getting to learn more about COVID, and we don't just have to presume from knowledge of other conditions.
Okay, well that's certainly reassuring to know. And indeed, Ben Goldacre's paper was my desert island paper last time. I think that was incredibly important. That kind of record linkage and those kind of numbers to give clarity where we couldn't before. Okay, now then. But the number one item that's come up with overwhelming numbers of questions about has to be the treating, the testing and tracing. And Margaret McCartney talked about that 2 or 3 weeks ago. A little skeptical on some parts of it, and it comes up time and time again on every time we have a webinar. Those questions come up. So. Now, I mean, even the acronym has changed, by the way. It was test and trace, wasn't it? Then test, trace, and isolate. Then test, trace, isolate, and support. And it's got even longer, and I've forgotten what the extra word is, but I don't think it's actually work yet. What's going on with all this, Sian? Help us out here.
The system, as it is now, as you know, under Dido Harding, so it's a very large system, and there are different pillars of testing, and some of the pillars are within the commercial sector, others are within PHE and NHS, and there's testing for both the antigen and the antibody within that framework. The key message about the test and trace system has to be that there are more tests available. the key has to be they have to be done quickly. And so as soon as somebody gets symptoms, the public have to be engaged in this. And I think that they really need to understand that anyone who has any symptoms can come forward, get a test, and it has to be done quickly. And the second thing is results need to be quick. And then the contact tracing can begin. And so the trace, the T of the trace, is about the contact tracing. And the contact tracing is three levels of three tiers. The first is that large call center. So when you get the first call you'll get will be from a call center that's been set up, working through an algorithm. If there are any complications, then you get referred to the second tier, which is staffed mainly by NHS trained staff. And then the third tier, which is actually called tier 1, so it's a bit weird, is Public Health England, who will go to situations such as care homes, factories, schools, and will be heavily involved in Leicester. Now, the other bit to this system, so you've got the contact tracing coming that way, is how do you engage locally? And that has been one of the biggest challenges, how to get local directors of public health, local authorities who are actually in charge of public health and across the population, fully engaged in this and linking into primary care colleagues as well as their local NHS. So I think nobody would claim that the system is working perfectly yet. But it is improving all the time. But one of the stumbling blocks has been flow of data. And that has been something that, again, you'll have heard in the reports on Leicester, that the flow of data hasn't come quickly enough so that directors of public health are able to look at their populations and say, we spot something going on here. They've had to rely on working closely with Public Health England. So there have been different sort of blips on the way. And of course, initially, we were going to have the app. As a public health person, I have to say that actually contact tracing is something we've done in public health for years, and that it's something that's tried and tested. You find out in your local population where where the case is. You talk to the case, ask the case to go into isolation, find out their contacts, talk to their contacts, ask them to go into isolation, provide them support, and keep on top of, break that chain of transmission. It's a very simple idea. It's one that's been in place in public health, as I say, for infectious diseases, actually over hundreds of years. And it's just one that had possibly been needed to be engaged more right at the beginning of COVID, and is now pushing forward. And I think this Directors of Public Health and Public Health England working well together, working at local level, is the way that it's best to do this, because that's the way you'll spot the new spikes if they come, and then be able to respond appropriately.
So the bigger question then is, explain to us how it actually is being run at the moment, because we have the impression that we're seeing, it's gone to a big conglomerate and you're having to go out to industrial estates spotted around England. But you're also talking about public health officials being involved.
Yes.
It seems confusing. The BMJ said, in fact, 90% is going on in local authority and only 10% nationally. Is that, just explain who actually is now doing it?
Well, as I say, put yourself in a local authority and make yourself the Director of Public Health. You, the Director of Public Health, will be getting information from Public Health England, and who will know who the cases are that you need, where you need to act. But you'll also be getting information from the central spine. I think it's not actually, the flow of information has been quite poor. It's getting better, and everybody says it hasn't been perfect. So it's getting better. But just at a local level, you'll want to know which school has been affected, which factory has been affected. You'll want to be involved. You'll want to work with the expertise of Public Health England. You'll have a local operating plan. They've been putting in place local operating plans. Those are new. They're being devised. You'll see different local areas working slightly differently, depending upon their geography, depending upon the people that they're linked with, that they link with in their local gold commands or whatever. And a lot of people in public health think that you really need to keep this very local, feed up the information to the biosecurity unit, because there's the new national Joint National Biosecurity Unit, which is taking an overview of all of this, which is also just being set up. So when you say how is it working, I think it's in development. I think there's a lot of activity. There's a lot more testing. They're talking again about mobile testing. So in Leicester, for example, where they know the numbers of cases, they need to do more testing. They're sending the army in with mobile testing. Now, when you have your test done, that's just having your test done. It's what happens to the test after that. It goes to one of the labs, and there are different types of labs it can go to. So there's a huge amount of data and communication that needs to go, sharing here. The important thing is the person who is infected gets the result quickly, goes into isolation. It may be through different routes, and that their contacts are traced, and that people have faith that they understand why they need to do this, because you need public compliance to make this system work. It won't work without public understanding that it's very important to, if you are a contact, to go into isolation for 2 weeks. You have to do that to stop the infection spreading. So in a way, all the infrastructure around it, which is being tweaked all the time, is almost secondary to the fact that at a local level, the information needs to be held by the directors of public health, sharing information locally with the trusts and with the GPs, and that the local network is set up. And local networks are working pretty well. I think that's the reason that Leicester is now getting on top of their spike, is that their local Director of Public Health has been talking to the public. He has the information, albeit some of it a bit slow. And the question now is, well, who actually has to make all the decisions? How do you get the decision-making framework into place? So it's a work in progress, but I will emphasize that it is actually the local level, usual public health that is necessary. Okay.
It's an odd thing, isn't it? The Independent this morning called for us to give up on the over-centralised approach that we have, but you're saying it isn't really that over-centralised, and using the Leicester experience.
I'm saying that the public health community are getting on with controlling the pandemic at a local level, because that's their responsibility. They're using tried and tested techniques, and that the over-centralisation is more a matter of collecting the data. And I think that I haven't seen that article in Independent, but some of it will be because, the question of who was to act in Leicester. This is the first spike where the question of are we going into a local lockdown is being asked, and then how does the local lockdown work? And I think that's where you have to say, who makes the decision? What decisions need to be made? And has the decision making been over-centralised in that situation? I think this is all the sort of way we learn. I mean, one of the things we learned from the SARS report was that whilst you're in the heat of the day, sometimes you do what you think is best at the time, but actually the lessons for the future may be different from what you did. It's not a matter of blame, it's just a matter of learning as we go along.
Yeah. All tells me that we'll soon be hearing from the Griffiths report on all this from the way that you speak about it so fluently. Okay, well, then let's then, Peter, I promised you and Nick to come back to the issue of vaccines, because that again remains in the news every day. But a couple of questions that we had Robin Shattuck from Imperial talking brilliantly a couple of weeks ago, but he didn't pick up on a couple of the questions. One is, it's about the issue of age. That one question is, are we going to need different vaccines by different age and demographics? And another has asked us about, would we not expect a weaker response in the elderly, precisely the group that are the most vulnerable? So tell us a bit about age and vaccines.
Absolutely right. But older people tend not to respond so well to vaccines, and you can get around that either by using an adjuvant or by increasing the dose of the antigen. So there are well-known ways of circumventing that problem. And certainly it is older adults who are suffering disproportionately from this disease. I mean, in terms of which of the vaccines are going to be most suitable for older adults, we don't know, because there's at least 8 in clinical testing at the moment. We're still waiting to see what the results are in terms of immunogenicity, but it is being tested. All these vaccines are being tested in people of different ages in order to try and determine, what their immunogenic profile is. But, it's too early to know whether these are going to be effective. Certainly with other diseases, we know that that it's likely that different vaccines are going to be used for different age groups for RSV when those become available, and I'm pretty confident they will. And for influenza, we are also tailoring the vaccination regimes for different ages, and live attenuated vaccines for nasal delivery may hold particular promise if you're trying to induce that local response, which is so important in these respiratory viral infections.
So mention of RSV and mention of influenza reminds us this is a very long job.
Absolutely. Yes.
I mean, how long have you been doing this kind of work? That's what I'm kind of asking.
So RSV was first characterized in 1956, influenza in 1922. So, this is a long haul. People have been trying to make vaccines for both of those. And I would say that, at the moment, the vaccines that we have for flu are suboptimal. They need to be better. There are many things about the flu vaccine which we would wish otherwise. We'd want it longer lasting, broader protection and so on. And so far, despite massive efforts by many, many groups, we don't have a vaccine on the market for RSV. So it's a long haul. It's amazing to see how fast this has been accelerated with COVID. Looking back just to SARS 2002, there was an editorial in Nature in 2003 saying it would be brilliant if within 4 years we could make a vaccine against SARS. That was the fastest possible that it was thought at that time that we might make a vaccine for SARS. So the fact that people are now looking maybe to have a vaccine tested at the end of this year and scaled up during next year is brilliant. Yeah.
Maybe, as you say.
Maybe.
So until then, there's certain things we have to live with. One of them, I think, will continue to be the virus. But the other thing we also have to live with is, of course, medical students. We've never done a session on training, actually, and we should have done. But those questions accumulate week on, week off. So, Nick, do you want to kick us off a bit about where we are with training? And in particular, how do we balance the needs of training of our workforce, both medical and, of course, non-medical, against the risks of it? I mean, it's causing chaos in our medical school. How are you coping in your role, in your
I think,
educational role?
Yeah, certainly. I think so. In training, I think the trainees are the postgraduate and the medical students. I think from the postgraduate perspective, it's been a really positive experience from the feedback I'm getting from trainees. They've learned things that they wouldn't have been exposed to before. CPAP, dealing with very sick patients, and they felt more confident managing sick patients, mainly because of the exposure, but also because our consultants have been freed up to deliver training on the shop floor. So I know I'm talking to the converted, the days when we had firms and our consultant taking us around have been lost, and really that has come back. So training's got a lot better from that perspective. There are elements where trainees who have craft specialties have missed out, and that is around the risk and to the patient and to the trainees. And I think you're right there. There's an element there where the craft specialists have missed that. And that's where we need to move forward with technology, with our simulation, not only with human factors training, but also with the simulators for different procedures, whether it's cardiac, bronchoscopy, endoscopy, the areas that are going to struggle. I think one note for the medical students has been that group of medical students that have qualified early and come and help the health service. And I think we should all be very proud of that generation that have volunteered to come to the front line. And in our own region, in Kent area in Sussex, I'm the head of School of Medicine there, our experience has been the trainees have been very welcomed. They've been a positive force and have kept the continuity when the other doctors are on the surge rota. They've kept that continuity and really learnt on the job. And they've been really happy with their experience. And for all of us, we'll benefit because come August, when the real job starts, they've been prepared to start and hit the ground running.
I think it is really good to hear some positive experiences, because we're hearing the same. There are a lot of people who've, really been learning and had a positive experience during the crisis. Not everyone, of course, but certainly some have. Peter, last to you. You also have a big role in medical education. Anything you want to add?
No, I think I mean, the experience is so patchy. I think one thing I would like to add is that something which is just really dawning on us is how impactful this is going to be in terms of many ongoing research programs and on the careers of researchers. You know, some people clearly are doing very well in terms of being able to do lots of research on COVID, but people who are doing some other types of study, you know, they just maybe received their first big award on which they were going to base their future career, and they can't do that work. You know, there's very variable effects on the careers of people in science, in medicine, and I think that's something we really need to think about.
There were some pretty disheartening statistics from neuroscience recently. On the other hand, that's been an announcement yesterday that we're all still digesting, and you as well, I'm sure are. Everyone is about some form of backup for that. I think that that whole has been recognised. And
also, I think we need to recognise the disproportionate effect on people who have domestic responsibilities. You know, that this is going to hold back the careers of people who unavoidably need to be at home looking after children, for example.
And I think we'll have to address that as well. And I think you're talking, the research has been showing the remarkable absence of females in first author papers of COVID at the moment. Right, but we are out of time. This is a longer version that we do once a month, but even that, all good things have to come to an end, and so this will as well. I should remind you that on Thursday we resume our series, and this time we're going to be looking at coronavirus in the older population. Jill Livingstone, a psychiatrist from UCL, Adam Gordon from Nottingham, and Judy Deshi from Tommy's. So a really big hitting lineup there, I have to say. And then in between, we have our Wednesday evening, more leisurely interview. Susie Walton will be interviewing Luke Johnson, one of Britain's most successful entrepreneurs, acquired Pizza Express in '93 and Patisserie Valerie in 2006. More recently, has not been having his cake or eating it since it collapsed into administration. And no doubt much to talk about there. So can I therefore now thank Nick, thank Peter, and thank Sian for being absolutely brilliant, as we knew you would be. Sian, we're going to hear a lot more from you, I'm absolutely sure about that. And no doubt Nick and Peter will be dragging you back as well as we continue this series. In the meantime, as I always say, the words of Hill Street Blues, stay careful out there. Thank you for watching, and good afternoon.
Bye.
Bye. Bye.